section is on law and ethics for behavioral science and psychiatry for faculty physician reviews. In this section, we're going to be talking about competence, informed consent, and legal cases you'll need to know for your USMLE. So what makes a patient competent? If they are able to understand the nature of their condition and understand the risks and benefits of treatment and withholding treatment and alternatives. Now, competence can only be declared by a judge. No doctor can declare competence. It is a legal term. Generally speaking, when people turn the age of 18, they are legally competent. They're no longer a child. And minors are legally incompetent. Some states will have laws that can cause emancipation through marriage, military service, or through the courts. In some states, if a minor has a child of their own, they are legally emancipated, but not in all. So for the USMLE, if you're married, if you're in the military, or you're legally emancipated by the court for issues of legal competence. So if those people are in your vignette, that they're under 18, married, and they're in the military, then they can make their own decisions. You don't have to tell their parents. But there's special circumstances where they have partial emancipation. And this is abortion, birth control, STDs, pregnancy, substance abuse issues, and physical or sexual abuse issues. So if you have an adolescent come to you and say, I need treatment for my abortion, I need treatment for my STD, I have some physical or sexual abuse issues I need to tell you about, you do not have to tell the family about it. Physicians must assume competence in their patient unless there is clear evidence of incompetence. And competent patients have the right to accept or refuse treatment, request second opinions, and also ask for alternative treatments. So when there is a question of an adult's competence, a judge is required to make a determination of the patient's competence. Doctors do not make the determination, but they can marshal evidence and make a clinical assessment. So they might be able to tell if their patient has some capacity, but they cannot document competence because, as we said before, competence is a legal term. So issues that are commonly arising are mental retardation, Alzheimer's and dementia, and mental illness including psychosis. If you are competent in one area, you might be incompetent in other areas. So say you have a demented patient. He may not be able to subtract 100 from 7 and continually subtract 7, but he might be able to understand that he needs to take his high blood pressure pills because if he does not, he can have a heart attack or he can have a stroke. So if you have a question about competence, it is only about the question that you have. It is not a global assessment of competence. It is about the specific question. Behaviors that are associated with incompetence include suicidality and psychosis that prevents the patient-physician communication or at any time that communication is jeopardized. Now, psychosis does not always mean that you're incompetent. But say, for example, a psychotic patient comes in, he needs a medical treatment, but he says, I'm not going to take it because I know the doctor's trying to kill me. Well, that means that he's very paranoid and that his delusion is preventing him from making a rational or a competent decision because doctors are generally not trying to kill their patients, they're trying to help them. So in that instance, he would be incompetent. His psychosis is impairing his decision-making capability. But, for example, if a psychotic patient is hearing voices, but he agrees that he needs to take his high blood pressure medicine or his diabetes medicine, well, that means he's competent. He's saying that he knows he needs to take it and he understands his illness. When a patient is declared legally incompetent, the court assigns a guardian who is responsible for using either substituted judgment, standard of best interest of the ward, and subjective standard. And we're going to go into detail about these three. And these three are high yield for your exam. So our first case is subjective standard, where we have Brother Fox, and this is an Aisha versus Dillon case. What had happened is that there was an elderly man about the age of 80 who had never had any illnesses, and he went into the hospital for a procedure and he had a stroke and was on life support. So they had to make a determination as to whether or not they wanted to take him off life support. And Brother Fox had actually told a friend a long time ago, you know, if I was in that kind of situation, I would want to be taken off of life support. So he had told someone else's wishes. It wasn't written down anywhere. He didn't tell his family. But in a conversation, he had told someone else his wishes. So in subjective standard, you're looking at what the patient's actual wishes are. Is there an advance directive where it's written down or it has been told to someone what the patient wants to be done in that situation? Did the patient tell others what their wishes would have been? So in his case, then the life support was removed because he had explained to someone else that he would want it to be removed in that situation. Substituted judgment. Is there one person who best represents the patient and the patient's best interest and wishes? If the patient were competent, what would they want? So substituted judgment is used when you don't know for sure what the patient wanted because they didn't tell you. They didn't write it down anywhere. You never talked about it. So you don't have the absolute what they want. But because you know them so well, you're either their husband or you're their father, their mother, you know them so well, you know that this is what they would want. So this is the case of Karen Quinlan, who was in a persistent vegetative state. And the family believed that Karen would have wanted the life support turned off even if it meant that she would die. So the court here uses substituted judgment standard. The court will consider the decision she would have made had she been able to express her own opinion. So this is based on what your best opinion would be for this person because they never told anyone. Next we have our standard of best interest. So what are the risks and benefits of treating or withholding treatment? And what is the best interest of the incompetent patient, not surrogate or other family? So standard of best interest is used when the patient was never competent. So this would be in the case of someone who has had mental retardation, who could never make their decisions for themselves. So this is the case of John Storer. And he was a man who had mental retardation, and when he got older, he had bladder cancer and repeatedly getting transfusions. And he was not a very verbal patient, but the mom believed that the patient did not want the continued transfusions, that he was in a lot of pain and they were not worth it, and she thought that he didn't need it. So here, if you're looking at this standard, what do we do when the patient has always been incompetent? The representative has no way to express what the patient, if incompetent, would have decided. So what happens is the court may apply a best interest standard of the patient. And that is, what would a reasonable person decide based on the risk-benefit assessment of treatment? So the court is worried here that the family member might be doing what they think is best for the patient instead of acting in the best interest of him. So instead they appoint someone in the court to make this decision as to what would a mentally competent person do. Next you have advance directives. If a patient is incompetent or unconscious, physician must follow advance directives, if any. And advance directives can be written or they can be oral. A patient, if competent, can elect to withhold or stop treatment, which could prolong a patient's life. So in an advance directive, specific instructions given by the patient to outline the types and the limits of care provided in the event that the patient becomes unable to communicate their wishes. So advance directives can either be a durable power of attorney, can be in the form of a living will. So what is a durable power of attorney? This is a designated person who is a surrogate decision maker about the health care when the patient is no longer competent. And a living will is a piece of paper where the patient gives directions for what to do about the patient's care when he becomes incompetent. So a document makes the decisions in a living will, not a person. So say a person becomes incompetent and they don't have an advance directive, then a surrogate is assigned. And if the patient has a wife or children, first the wife becomes a surrogate, and if there's no wife, then the children, followed by his parents, or if he has siblings. But say if the patient has no family, sometimes the chaplain can be the surrogate, or sometimes they may have to go to court and court decides on another surrogate. So the surrogate must follow the patient's wishes and not the surrogate's personal wishes. And if an incompetent patient comes back to competency, then he regains complete control of his health care. So what is the criteria for a surrogate? What did the patient want? What did the patient actually say? And what is in the best interest for this patient? So we've talked about informed consent, but there are 5 elements of informed consent. So before doing any kind of procedure, giving any kind of medication, these are the 5 elements that you want to go through and see that your patient understands to see if they're competent. 1, the nature of the procedure, the purpose of the procedure, the risk of taking it, the risk of not doing it, the benefits, and if there are any alternatives to the procedure. And physicians must receive consent from patients prior to any medical intervention. It can be written or oral, but you must document. And the patient must be competent and fully informed. You must go through the 5 criteria of the informed consent. And the only exceptions when you do not need to get informed consent are as if the patient's incompetent, there's a life-threatening situation where they're losing life or limb in an unconscious patient, a waiver by the patient, which means, Doc, I trust you, I don't want to know, just do what you got to do, or any short-term interventions. For example, if a patient's delirious, you know it's due to some kind of medical cause, you're going to fix it, you want to give him a little Haldol to control his agitation, or a short-term intervention, there you would need an informed consent. So in an informed consent, they must understand their diagnosis, the implications of their diagnosis to the patient's health and the longevity, understand the risks and the benefits. They can withdraw their consent at any time. So a patient may agree to have surgery and you take them into the operating room and they might say, hey doc, I've decided to change my mind, I don't want to have surgery. You got to wheel them right back out. You can't continue with the surgery. They have a right to change their mind at any given time. And in a research situation, patients must give complete consent. And if a patient's condition worsens during the study, they should be removed off the medication and given the normal standard of care. And voluntary means consent given without coercion. So when you're a doctor giving consent, you're just giving the hard facts, you're telling them the risks, the benefits, you're not going to tell them your opinions or what you would do because you do not want to coerce this patient into having a procedure. So competent patients can refuse treatment even if treatment is vital for patient survival. For example, Jehovah's Witness, if they don't want to receive blood because of their religious ideas, then you cannot force them to give it. Pregnant women can refuse an intervention to save their child. Family members cannot influence what or when the physician provides information to the patients. So for example, a lot of times families will say, don't tell my mother that she has cancer because she won't be able to handle it, or because we don't want her to know, we think she'll just better off if we'll tell her something else. But you always have to tell the patient, especially if they're competent, what's going on with them. But say, for example, you feel that if you were to tell the patient some kind of information that would threaten their health, then you can withhold it temporarily, but eventually you must tell the patient. And if a physician finds a life-threatening situation during surgery which they did not expect, they can perform standard of care measures without any additional consent. Next we go to confidentiality. We have something called HIPAA, and what HIPAA means is that physicians cannot discuss a patient's care or anything to do with the patient to any third party without express written permission from the patient. And the permission has to be specific. You can't just get a blank document saying, Mr. Jones, I want to talk about your health care to anyone that asks. You have to say, Mr. Jones, I want to release your information to your insurance company, to your family. The court may ask a physician to violate confidentiality if information threatens the lives of the patient or others. So when you have a patient and you go to see them, and say they have a family member visiting right next to them, the first thing you want to say is, hi, Mr. Jones, I'm Dr. So-and-so. Who is this sitting next to you? And they'll say, oh, it's my sister. And then you'll say, well, is it okay if I talk to you with your sister about your problems, and if he says, no, I don't feel comfortable, then you can have his sister leave. But if he's comfortable with it, then you can have his sister stay in the room. So it's basically protecting the patient's rights. So why would you violate confidentiality? One is terrace off, and that's the duty to protect and to warn. And say if a patient comes into your office and says, I want to kill myself, but before I do that, I'm going to kill my wife. So what that means to do is that you have to keep this patient from going to hurt them, so that means you might have to transfer them to a hospital, and you need to warn his wife that he has made threats to kill her, so that that way she can protect herself. A patient is a threat to self or others, or a reportable disease by the health department. Certain sexually transmitted disease, hepatitis, AIDS, all of these are reportable diseases. So there are certain names that we should know for law and ethics. First is autonomy, and this is the patient's right to make decisions in his best interest based on the information you've given him. Beneficence, the responsibility to act in the patient's best interest. And non-maleficence, do no harm. And occasionally on the USMLE, they will give you the definition of one of the three of these words and ask you to identify the word. On the exam, euthanasia and assisted suicide are not acceptable. So it is not ethical to allow a patient to die. You cannot assist in suicide. Please remember that on your exam. And you should always make sure that a patient is not depressed and suicidal when they're electing to die, because that means that they are incompetent. And also, you also want to make sure that if a patient is in severe pain and they have cancer, that they have enough pain medication to make them feel comfortable if they're dying. Do not resuscitate orders or DNR orders. All terminal patients should be given an option about this. And there's different levels of DNR orders. Some patients don't want any medications. Some patients don't want you to do the compressions. Some patients don't want you to do the ventilation. You have to be very specific in asking the patient what they do and do not want. And DNR orders and advance directives can be made by the patient or their appointed surrogate. And if a physician knows that a patient has a will to hurt themselves or to hurt someone else, they have the right to hold on to these patients. Courts can commit patients to involuntary psychiatric admissions for these reasons. And children who pose a danger can be committed by the court or by the parents. This concludes our first portion of Law and Ethics for Behavioral Science and Psychiatry for Falcon Physician Reviews. This concludes our first portion of Law and Ethics for Behavioral Science and Psychiatry for Falcon Physician Reviews.